Dr. Lenze is the Wallace and Lucille Renard Professor of Psychiatry at Washington University and the director of the Healthy Mind Lab. These are at our School of Medicine. Dr. Lenze is a clinical trialist who has successfully advanced evidence-based medicine for depression, anxiety, cognitive disorders in later life. He has advanced the concept of the precision clinical trial, which is a framework for using clinical trials to advance precision medicine in neurobehavioral disorders. Very innovative work, also incorporated mobile and internet technology in clinical trials. So a long and impressive list of accomplishments, and is our top geriatric psychiatrist at WashU. And he is joined by his colleague, Dr. Holzer. Dr. Holzer is a social worker by training and has experience in psychiatric social work at Barnes-Jewish Hospital. Completed her PhD, is a researcher now with Dr. Lenze, has an appointment at the School of Medicine, and is the administrative director of the Center for Perioperative Mental Health. And that's what we're going to be learning about today. Very excited to learn about this work. So Eric and Katie, take it away.
Thank you, Nancy, for that very kind introduction. To be clear, I'm the only geriatric psychiatrist at WashU, so being the top
at the same time.
It's a low bar, but I'm going to go ahead and share my slides. Hopefully you see my slide. If you don't, then let me know. But the geriatrics 5 M's was a new way of describing competencies in geriatric medicine created by some 3 geriatricians, and they include mobility, mind, including depression and mental illness, but also cognitive impairment, medications, particularly polypharmacy and adverse effects of medications, complexity, referring to the multiple illnesses and frailty and similar problems that older adults, and finally matters most, meaning that to older adults, what matters most are often individual goals and wishes for their medical care. And to talk about perioperative mental health, we first have to talk about geriatric mental and cognitive health, and that's what I'll talk about, and then I'll turn things over to Dr. Holzer to talk specifically about its application in perioperative mental health. One important way to think about this is the science of perioperative mental and cognitive health. And I'd argue it's all related once it gets to the brain. That is, the same pathways underlie outcomes that matter to all of us in the field. So what I mean by that is, if you look on the left here, there are multiple pathways to dysfunction of the brain: neurodegenerative illness like Alzheimer's disease, long-standing deficits, which could include even results of childhood trauma or adversity, acute changes due to medical illness or late onset mental changes, and then medication effects as well, particularly if those medications tend to be CNS depressants. Those cause changes, dysfunction, if you will, in key brain networks, which underlie virtually all of the outcomes that we study. And of course, different departments and schools at Washington University will have different interests, like cognitive dysfunction versus mental illness versus sleep dysfunction or delirium risk or caregiver distress. But those same pathways into the brain affect all these outcomes that matter. There's a lot more that unites us than separates us in the field of geriatrics. But when we turn to real world care, specifically in geriatric mental health care, those 5 M's that I described earlier collide into what I call the 4 A's, where real world care isn't good. That is, inaccurate assessment, low adequacy of treatment, little use of psychosocial approaches, and alarming rates of inappropriate medications. I'm going to get into each of those one by one now. Good care begins with good assessment. And fortunately, there are simple, straightforward ways to add measurement-based assessment into geriatric mental health care. Seen here are two excellent and commonly used scales, a scale of depressive symptoms called the PHQ-9 and a scale of anxiety symptoms called the GAD-7. Despite their use, their good use both for helping to diagnose and rate the severity of illness and follow treatment response, unfortunately, these are far too often not used in a multitude of settings, including primary care and mental health settings. What's the result of that? Well, we miss the opportunity for the superior outcomes of measurement-based care. Here's an old randomized controlled trial. It was not in older adults, but it was in people with depression, where interestingly, the study did not randomize people to a particular treatment or not. It randomized them to get either standard treatment, that is, the psychiatrist's judgment determined whether and how to make medication changes, versus measurement-based care, where a depression scale guided dose adjustments and switches. And what you can see there in this time to response analysis is that measurement care beat standard care in terms of getting people more quickly to remission from depression. And in part, that was getting people more quickly to adequate treatment for depression. But what is adequate treatment? Well, we know a lot more than we did maybe 20 years ago about adequate treatment for mental illness, particularly depression in older adults. Adequate treatment is the use of algorithms, it's the use of dose optimization, and it's the use of augmentation treatments. So here's my recommendation to those who treat depression in older adults. Use an algorithm, use an antidepressant algorithm, and follow it. Don't persist with ineffective treatment. At the top of most people's algorithm with medications is an SSRI for many reasons. They're inexpensive, widely available, safe, tend to be well tolerated, and easy to use. But if that doesn't work, move on, move to a new class. In my algorithm is the SNRIs, serotonin norepinephrine reuptake inhibitors, medicines like venlafaxine or duloxetine. There are other possible second-line agents that I have listed here, but they tend to be more expensive as they're patent protected, so I don't tend to use them. But then if those first two steps do not work, do not get someone well from depression, it's time to either switch or more likely augment with one of the treatments listed. And if things are still not working out, the patient needs a psychiatrist. Together with that algorithm, we can use certain guiding principles. We can personalize treatment. Don't retry a drug class. If one SSRI doesn't work, try a new drug class like an SNRI. Conversely, do retry a medication that worked previously. If your patient tells you, I was on a certain medication and it seemed to help, that most likely should be the top of your algorithm, regardless of the medication. If you can't personalize, you can at least avoid drug interactions and known risks by choosing more simple, straightforward, and safe medications. And finally, give an optimal trial. Make sure to give someone an adequate number, an adequate duration at an optimized dose before calling it quits with a medication. And what do I mean by dose optimization? Many patients are on suboptimal doses of antidepressants, never pushed up to a higher dose. In geriatrics, we do start slow, and we do go slow, sometimes too slow, but we don't necessarily want to end low when it comes to antidepressant dose. And then why do we augment treatment? It's a simple equation. 1 + 1 is 2. That is, treatments for anxiety and depression, individual treatments tend to have a modest effect size, which means that a single treatment approach, a single medication, for example, will usually be inadequate. And so if you're using that PHQ-9 and then seeing a patient in follow-up, you may see a scenario like this one, where the patient has a reduction in symptoms of depression on the PHQ-9 and in their report to you, but they still have significant symptoms of depression. What we've shown in our lab is that medication augmentation works. That is, adding a second medication, in this case, a low dose of the medication aripiprazole, was efficacious and for the most part well tolerated and safe for late life depression. But I want to add that psychotherapy augmentation works as well. In this study of older adults with anxiety disorders who we first started on the medication escitalopram or Lexapro, we saw a much more robust further benefit in terms of anxiety and worry reduction for those who were added or augmented cognitive behavioral therapy. And in general, psychosocial strategies for older adults are increasingly evidence-based. They're increasingly widely available, but they remain underutilized. Here's my go-to list as far as psychotherapies. And to be clear, these are all fairly simple, straightforward psychotherapies that can be done in a finite number of sessions. And they're all evidence-based. For depression, behavioral activation and problem-solving therapy. For anxiety, relaxation training, maybe one of the most underutilized types of psychotherapy out there. And finally, for insomnia, cognitive behavioral therapy for insomnia, which I hope that everyone listening has heard of, thanks to our excellent sleep medicine group at WashU. But I want to also point out other things that are helpful. Guided self-help, where you're not conducting formal psychotherapy with a patient, but pointing them towards self-help resources, books, increasingly the internet resources or apps, and you're guiding them to good resources and prompting them to utilize them. Mindfulness, which is a component of some psychotherapies, but is also a practice itself, has increasing evidence to be helpful for older adults. And then cognitive training, what you might call brain games, whether it be computerized brain games or even paper and pencil ones, seem to be helpful not only for cognitive function, but depression in older adults as well. Let me move on to then deprescribing. What is the definition of deprescribing? Realizing that there are many of us on this meeting today for whom the word didn't even exist when we started out in our geriatric practice. I'm not going to name any names there, but this word did not exist when I started out as a geriatric psychiatrist. It is the process of withdrawal of inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. To be clear, it is not withholding of care. In fact, it's increasingly science-informed practice. I wouldn't call it a science unto itself, but a practice informed by several areas of science. From the left to the right, the field of epidemiology alerting us to rising levels of CNS or central nervous system medication polypharmacy. That is, older adults who are taking 3, 4, 5 or more medications that all get into the brain and have CNS effects at the same time. Then geriatric psychopharmacology, which is telling us not only that aging increases medication risks, but telling us more and more about what those risks are and how they occur. Behavioral science giving us the tools to change people's minds about their medication use, which might be quite entrenched if they have been taking them for the long term. And finally, the increase in patient-centered medicine, allowing us to focus on outcomes that really matter. And this leads to deprescribing of benzodiazepines, anticholinergic medications, and drugs that have interactions. And this is particularly important in mental and cognitive health. Why? Well, mainly because patients we see are on a lot of medications, and many of them affect the brain. In a broad list, I think of psychiatric drugs that we in the mental health field prescribe, added to psychotropic drugs that others who are not mental health practitioners are also prescribing, added to that non-psychotropic medications that nevertheless enter the brain and therefore can cause CNS effects. And finally, over-the-counter medications that also enter the brain. So who cares? Why is it important? Well, let me put a human face to this. I'm sure a lot of you have heard this story. This was a tweet sent by Bob Saget, famous for America's Funny Home Videos and Saved by the Bell. He was doing stand-up comedy for a weekend in Jacksonville, sent out a tweet describing what a great, enjoyable night he had. Said, "I'm happily addicted again to this SHIT, this comedy, and looking quite happy." Unfortunately, later that night, Bob Saget died. He died of an injurious fall, and found in his system was not alcohol, not illicit drugs, but prescribed medications, clonazepam, a benzodiazepine, as well as trazodone. So when we think about deprescribing, here's the point. Think about brain toxic medications in older adults that cause falls, cognitive impairment, and delirium. How do you do that? How do you deprescribe? The first tip, make a list. Make a list of all potentially brain toxic medications. Categorize them into benzodiazepines and other CNS depressants, and then strong centrally acting anticholinergics and antihistamines. And make sure they include over-the-counter drugs and ask carefully about those. I like to ask, do you take any over-the-counter medications? Like for sleep, or for example, or allergies. For example, Tylenol PM or Benadryl. I find that those multiple prompting questions are necessary to find out. And let's not forget that the over-the-counter sections of our grocery stores and pharmacies are chock full of brain toxic medications. You can walk from one aisle to the next. You go to the sleeping medication aisle where you see Unisom, powerful centrally acting anticholinergic and antihistaminergic. Next, over to the arthritis aisle where you'll find Tylenol PM, same. Next over to the medications for motion sickness, same. And then next over to the cold and flu aisle where you can pick up some NyQuil, same. Next, make a plan. As I said, we can categorize these brain toxic medications in two broad categories. The first one is the strong centrally acting anticholinergics and antihistamines. I'm talking about certain bladder medications like oxybutynin, certain bowel medications like dicyclamine, and other medications, older tricyclic antidepressants. These are the easy ones. The hardest thing to do is identify them in the first place. Once you do, usually you can stop them immediately. No need to taper. Now, some may be helpful, like tricyclics taken for pain or other somatic syndromes, or they might be perceived as helpful by the patient. Whether or not they are, it's the patient's perception that matters. For example, the overactive bladder medication. In those cases, we can switch to a less harmful medication. For example, one that doesn't get into the brain or isn't such a strong anticholinergic. And the message matters. Simple, patient-friendly language around their goals can bring home to the point to patients why we're doing this. So I often have conversations just like this with patients. You know, Mr. Smith, you told me you're really concerned about your memory. Yep. The good news is we can definitely help you with your memory today. Okay. You take Tylenol PM. It causes memory impairment and confusion. Wow. All you have to do is stop it. I guarantee your memory will get better. Great. what you can see is that the conversation is made at a patient level, meeting with the patient's goals and explaining the treatment, that is the deprescribing, in a way that the patient can easily understand or is meeting their goals. Part two is benzodiazepines. These are harder for three reasons. One is you need to taper them. Unless they're at a very low dose or taken only intermittently, you need to taper them and taper them slowly to avoid a withdrawal or rebound. Two is people, particularly those on the higher dose, if once you taper them down and off, you may undermask an underlying anxiety, depression, sleep problem. My response to that, not to be too glib, is okay, you've unmasked that problem, then treat it with something other than a benzodiazepine. And finally, and the more compelling issue is their habit forming. On a very neurobiologic level, patients like them. And just as an example of the challenge to that, I'm going to remind us of the recent STRIDE study. This was a huge randomized control of a multifactorial strategy to prevent serious fall injuries. Despite the enormous amount of effort and expertise of the people conducting this trial, this is what they found. What you can see is time to first serious injury from a fall in the intervention group versus a control group. And what you see is no significant difference in this large study. One of the things that they concluded in that study was that they encouraged participants to choose recommendations they were willing to address. And they said, for example, only 29% of participants who were taking a medication identified as a risk factor, that is a fall risk medication, even agreed to address this. So with that as our background, we realized that the message really matters with benzodiazepines. So this is the conversation that I frequently have with patients. You're taking clonazepam. You can see that the patient is suspicious of where this is going. The problem is that this medication causes older adults to fall and have hip fractures. That will get their attention. Yikes. It also causes memory impairment, like you get with Alzheimer's disease. Eek. Fortunately, if we reduce and stop it, you won't have these risks anymore. Whew. So it's not enough to simply explain the benefits of these. You have to explain it in a way that's very clear on an emotional level for patients. And I'm going to stop here. I'll just again make the point, simple geriatric principles make the difference. With some simple principles, we can do measurement-based care, we can follow algorithms, we can use dose optimization and augmentation approaches. We can and should use more psychosocial approaches, and we can deprescribe and avoid bad medications. That's the basis. Now I'm going to turn things over to Dr. Holzer, who's going to describe how do we apply these principles to perioperative mental health.
Great. Thank you, Dr. Lenze, and thank you, Dr. Moore-Howell, for having me. So yes, I'm going to talk about applying the principles that Eric just described to the perioperative period. And what I mean by perioperative is that period before, during, and after surgery. Next slide. Okay, the reason why this is important to focus on now, and particularly with the silver tsunami, which is the aging of the population, how it's termed, and then the surgical tsunami, they're kind of meeting. So we're having a rise in surgeries and the aging of the population. And reason why this is important, especially in older adults, is those older adults with depression, anxiety, maybe cognitive impairment, and polypharmacy tend to do worse after surgery. They may experience delirium, pain, impaired recovery, and longer-term poor quality of life. An example is a 75-year-old woman undergoing oncologic surgery. She might have clinically significant depression with co-occurring mild cognitive impairments. be on medications, those brain toxic medications that Eric mentioned. She's prescribed an antidepressant by her primary care physician, but it's not in an effective dose, and she's not receiving any behavioral treatment. So if we think about what her outcome will be post-operative, immediately post-operatively and longer term, it's not great. Those impaired functioning, worse quality of life. In the past, perioperative care has focused on the specific operative problem. Was that problem solved? And the success of the operation, and then whether the patient survived. Currently, we're seeing care expanding to more of the patient. So more of the patient's physical health, those medical comorbidities. There's been a focus on frailty. And it's included a period of what is called prehabilitation. So preoperative physical optimization, early mobilization right after surgery, and then postoperative physical rehabilitation. What we're saying is needed is a focus not only on that physical health of the patient, but also mental and cognitive health, and delivering those behavioral interventions and medication optimization that we know works to the right patient at the right time during the perioperative period. And that brings us to the idea for the Center for Perioperative Mental Health. This is led by Eric Lenze and Michael Avedon from the Department of Anesthesiology. And this is now an NIMH funded center. And we are doing just that, applying those principles that Eric described to the perioperative period. And this is the first Center for Perioperative Mental Health. And I'll describe what we're doing in our primary study right now. I talked about the perioperative period, that's before, during, and after surgery. So when you're tailoring an intervention to this period, we're looking at starting right when surgery is scheduled, and you have this bit of time, and I'll go into this in a bit, the preoperative period. And that is, you're preparing the patient for surgery, you're conducting or delivering these behavioral and pharmacological prehabilitation interventions. So starting that prior to surgery. In the hospital, we're really focused on the patient experience, continuing these interventions, specifically the medication optimization, those recommendations that are made, just making sure that they continue throughout this period, and then post-operatively continuing those interventions up until 90 days. The challenges for this setting, if you've undergone surgery or cared for someone who's undergone surgery, you know it's complex. So lots of different clinicians involved. The patient is changing hands multiple times. That leaves lots of room for error. These patients are also complex. They may be on multiple medications, have seen doctors, have been followed by multiple physicians. And because of those complexities, they have higher needs. And we have to make sure to attend to those needs, the physical and the mental health. And then the short runway that we're calling it. So as I said on the last slide, we're starting the intervention, or we hope to start the intervention right when surgery is scheduled. That could mean we have a day until they actually undergo surgery, or it could mean a week or a month. It just depends. And so we have to find out how to adapt an intervention to this perioperative period, knowing that for some patients, in order to get this intervention in before surgery, that could mean just having a day of time. And Eric describes some interventions that could be tailored to the perioperative period that we know work. We just have to adapt it to this setting. This is behavioral activation, and this can be a standalone therapy. It can also be used with cognitive behavioral therapy. And what this is kind of a fancy name for a really simple treatment. And patients with their clinicians, and we refer to our clinicians or our interventionists as perioperative wellness partners. So they talk with the patient about their values, they assess their values, and then identify activities that matter to these patients and align with their values. These activities could be anything from mindfulness, meditation, to those brain games, or even just calling a friend or taking a walk or playing chess. Pharmacological optimization, that's what Eric has described. So taking patients off of those brain toxic medications if they're on them, and then optimizing or increasing the dosage of their antidepressant medication. And again, applying preoperatively and then continuing throughout the perioperative period. In order to make sure that these interventions are feasible in the real world, and that if we do find that they're effective, that they will be implemented, they have to be informed by implementation science. And fortunately, we're at WashU and we have incredible implementation scientists here. So I'll take you through the 5 phases of our implementation plan. The first one is analyzing the problem. So the depression and anxiety in older adults that are undergoing surgery and our intervention bundle. And the way that we've done this, because we're now in phase 2, is that we've met with stakeholders. We have an internal and external advisory boards that really helped us analyze the problem and develop an intervention, which we're now in phase 2, testing the feasibility of the intervention and adapting it to the perioperative period. In phase 3, we'll look at the results of our feasibility test and adapt the intervention bundle based on the results of our feasibility phase and come up with an implementation plan, which we will then conduct in a randomized controlled trial, which will be after this feasibility stage, likely in the next year or so. And finally, after conducting the randomized controlled trial, we would take that information, integrate those results, and hopefully implement this in real world settings. The randomized controlled trials that I mentioned, this would be done in older adults undergoing major orthopedic, oncologic, or cardiac surgery with current depression or anxiety symptoms. One of the things that we've found during our feasibility stage actually is our enrollment to include older adults 60 and older, maybe one of the changes that we make based on this feasibility stage. We'd enroll 100 patients, 50 in the treatment arm. Preoperatively, you're assessing the patient's mental health needs, starting that behavioral activation, making those medication recommendations, optimizing or deprescribing those harmful medications. In the hospital, again, the focus is on the patient experience, making sure that those medication recommendations are continuing, the optimization and the deprescribing, and then communicating with the patients and their needs. And then post-operatively, continuing the mental health intervention bundle, which is what we call our behavioral activation and medication optimization. And that could look very different post-operatively. The activities that one can engage with or even their values may have changed from the preoperative period to the post-operative period. So we have to be very adaptable to this setting, which, as I mentioned, is complex. And then communicating with their mental health care team if they have one, or their primary care team on the outpatient setting. And next. In terms of outcomes, of course, we're interested in the depression and anxiety at baseline and postoperatively at 1 month and 3 months. Also, quality of life in the hospital. We're assessing patient experience, incidence of delirium, and their length of stay. And then in addition to depression, anxiety, and quality of life postoperatively, we're looking to see if the patients were rehospitalized or fell. And I just described the primary study of the CPMH at this time. We also have the incredible opportunity to fund pilot projects, and we've funded 4 this year, and it'll be open again next year. So really just within the broad research area of perioperative mental health. And this is a great opportunity for junior faculty or trainees to be mentored by the CPMH faculty if anyone's interested in getting into perioperative mental health. Again, the center has some funds for that. And this is open to anyone at WashU, but also the Goldfarb School of Nursing and expanding to the pharmacy school. And you receive mentorship by our CPMH team, which on the next slide, I'll show you our impressive team. So we have our stakeholder advisory boards that have been key to this implementation process. And we have internal advisory boards and external advisory boards with experts across the country, including our patient partners. Our cores, the methodology core is led by Joanna Abraham and Phil Miller. We have experts in implementation science and stakeholder engagement. That's Anna Bauman, Mary Politi, and Beth Prusasic. Patient experience, Mary Politi and Jen Karen. Informatics, Thomas Konapel and Joanna Abraham. And then our projects, I mentioned that we are doing RCTs in 3 different surgical populations. Our orthopedic surgery is led by Ryan Calfee and Eric Lenze. oncologic surgery led by Chet Hamill and Benj Kozar, and then cardiac surgery with Simone Haratunian, Ken Friedland, Michael Avedon, Kunal Kotkar, and Faraz Massoud. And then those RO3 projects. If you're interested in this work or collaborating with the center, I have our website down there, and we can send that out as well. It's perioperativelwellness.wustl.edu. And of course, this is led by Eric Lenze and Michael Avedon.
Okay, I'm going to stop share, and we covered a lot of ground in a short time. That was by design, because we were hoping that there'd be a lot of discussion and Q&A.
Yeah, Eric, do you want to take the questions that are in Q&A? Would it be helpful if I read them to you?
I can read the
Great.
first one. Please, this is from Lenice Cummings Vaughn. Hi, Lenice, thanks for attending today. Please describe what is involved in behavioral activation and problem-solving therapy. And I think this is something we can answer live. I'll tell you what, I'll let Katie, Dr. Holzer, answer on behavioral activation, and then I can answer on problem-solving therapy.
Yes, so behavioral activation, again, is very straightforward. You're assessing the patient's values first and looking at what activities they engage in during the day. And you're trying to find activities that align with their values. And the rationale behind that is doing more of what matters to you will make you feel good. And it's a reinforcing cycle where you'll continue to do those activities, and they might be in the place of activities that don't make you feel good. And what the therapist does in addition to assessing and identifying their values and finding, helping them find activities that align with their values, is also they hold them accountable. So they schedule these activities. As we all know, if we try to do something, but we don't put it on the calendar or don't hold ourselves accountable, we might not do it. So it involves holding the patients accountable each week, scheduling these activities, making sure that they're going through with them, solving any barriers that might get in the way of these activities, and working with them throughout that whole period. And then Eric, you want to talk about problem solving?
And to be clear for those listening, particularly those MDs listening, problem-solving therapy does not mean that the patient describes problems and you try to solve them for them. Okay, so problem-solving therapy refers to a way of giving the patient skills to recognize their problems and then break them down into smaller and solvable problems. So what you're doing with patients is giving them both a set of skills for dealing with their real world problems, but also allowing them to view things more positively. That is, viewing problems in an optimistic light and embracing self-efficacy or self-mastery. And to be clear, neither behavioral activation nor problem-solving therapy is something you can easily do inside of like a single 10 or 20-minute visit. Personally, that's why when I see a patient who needs psychotherapy, I tend to refer them to a skilled psychotherapist rather than try to do it all myself within the confines of a single appointment. But the important thing is that these are relatively pragmatic, straightforward interventions. They often take only a few sessions. And we do have several excellent schools of social work here in the school. And so there are many therapists in the area who are graduates of those or masters in counseling program who are skilled at doing those therapies.
Great. There's some real good questions coming. I hope we have time to get.
Let's see.
Oh yeah, sorry, I was muted.
I'll
You
ask
ready
the
to
next
take
one out loud. Do you want me to say?
Please. Yeah, I think that'd be great.
This is by Peter Sun. Is a takeaway from the STRIDE study to prevent the falls that the intervention may in fact work, but even with sufficient power, it's hard to establish that. Is this kind of negative result more common in geriatric research? Great question. And I think that the broader point is there's a number of ways that an intervention can be found to not work in a clinical trial, right? One is that the intervention itself may be insufficiently robust. Like, for example, for fall prevention, people tend to find that like single interventions, like only deprescribing and not doing anything else about fall prevention, is insufficiently robust by itself. There may be poor adherence with the intervention, which maybe this in the STRIDE study was an example of. That is that patients did not want to change medications, but there may be also poor fidelity with the intervention, that the intervention was actually not done as it was originally defined in the study. That's very common, unfortunately, in multi-component intervention studies. And finally, the outcome measure may have had inadequate assay sensitivity. We don't know what happened exactly in the STRIDE study. But personally, I think they probably should have done some implementation research before they started the study rather than afterwards as a kind of post-mortem. And you asked if it's more common in geriatrics. It is common in geriatrics because we tend to do a lot of multi-component intervention research, but unfortunately not unique to geriatrics. I think this will be a good one for Katie. This is from Brian Carpenter. Based on what you've seen in perioperative settings, to what extent are other family members involved, and how do interventions engage family?
Yeah, so actually, part of our internal advisory board period, when we were planning the intervention, is meeting with patients and caregivers as well as clinicians. But we found that caregivers, of course, are really heavily involved in this period, and that it's important to include them and they want to be included, and that the patient wants to include them. They want them to get this information. Even during this feasibility stage, when we're doing the intervention, you'll hear a wife of a patient in the background saying, well, these are the activities that you do. This is what matters to you, and continuing and holding them accountable. So helping them schedule the activities. So we have really heavily engaged caregivers, I think, in each of the patients so far. That's what we're seeing. And, we welcome that. And so, it's an individual therapy, but it's up to the patient preference, and that's what we're adapting during this stage. If we find that caregivers are as involved, we may just more systematically involve them in the RCTs. But yeah, we're finding that they're involved during this stage and want to be involved.
Ken Friedland asks, are there any complementary medicines that may require deprescribing in older adults? And how about marijuana, which unfortunately I think is increasingly being seen as a complementary medicine by older adults? Marijuana, yes, frequently. I often will say, well, marijuana causes memory impairment, and that's a pretty helpful statement to make with older adults. I would say that this is we're in early stages with this, with the increase in marijuana use in older adults. I don't know that I have a really good answer for that, Ken. The only other one I can think of is melatonin, which I think we often favor it because we view it as not superior, but more safe than benzodiazepines and Z drugs and prescription sleeping medications. But at the same time, what we've recently found out is that's led to a massive increase in melatonin use in older adults. And so I think whether that's going to require deprescribing is less clear at this time.
Eric, could I jump in because Dr. Burge had put a question in chat, and I'm kind of paying attention to the timing the questions came in.
Oh, okay.
Do standardized post-op orders still include Zolpidem and Ambien for sleep?
Well, I don't know. I didn't write any of those post-op orders. I don't know, Dr. Holzer, if you know the answer to that, or any of our operative people know the answer to that. I don't think so, but I believe that that practice has been abandoned. I sure hope so.
Thank you.
But
So you,
I think it's a broader good question, is how might one launch better perioperative care, and including deprescribing on a systems level with, for example, automated orders that stop medications that are started, like benzodiazepines and sleeping pills that are started in the hospital. So I think it's a great question.
great. Okay, you can go back to your Q&A list now. I just wanted to get Stan's question in there.
All right. I don't know if either of us has the right answer to this question, but we'll see what Dr. Holzer thinks first. What patients do you believe are good candidates for the use of mindfulness? And what tools do you like to use to teach this technique?
So during this feasibility stage, while we've been working with patients, we have seen that the patients that are drawn to the mindfulness or select mindfulness and these options of activities that we've given them are those maybe more anxious patients, especially the ones that are anxious about the upcoming surgery and maybe anxious about getting back to their old way of life after surgery. So we've, again, they're given the choices of different activities to engage in, and they get to pick it. It's based on their preference, but we are finding that more of those anxious patients are choosing the mindfulness and meditation. And the tools that we're using right now, we want this to be open and be able to be implemented in the real world. So we've used YouTube videos. We're also using Mindful My Way. You can Google that, but those are the programs and the booklets that we've been using so far. But again, just any tools that we have at our disposal, including YouTube videos and applications on your phone.
And then how common is measurement-based care in hospitals nowadays? If a patient brings it up, would the physician be able to switch to such an approach? I'll just clarify what I described it in terms of measurement-based care is outpatient care, where you make switches and dose escalations or augmentations based on ongoing measurement in patients. And how that would work in an inpatient setting or a perioperative setting is unclear. One of the things that we're trying to do, maybe the key thing we're trying to do with the new perioperative mental health center, is to figure out how to adapt these geriatric principles like measurement-based care into what Dr. Holzer described as this much more time confined, yet much more complex as well, setting of perioperative medicine. So I guess if I don't think a patient would bring it up, but I would probably just say that's really more of an outpatient thing than the inpatient thing. Tim Holden said, excellent talk. Thank you. Thanks, Tim. Are you going to exclude people with cognitive impairment in this study? We allow some degree of cognitive impairment. We do not allow full-on dementia. And then if so, future plans on potentially expanding the intervention to individuals with dementia. And that is a great point, Dr. Holden, because you know as well as we do that the people who are most likely to have some of these severe problems perioperatively, falls, delirium in particular, and a very challenging recovery, are those who are living with dementia in the first place. I guess I would say that for very old and probably obsolete reasons, there's this split between NIA, which funds dementia, and NIMH, which covers mental health care, which I think, as you heard in my, we're all related, it's all connected. You hear where, what my thoughts are about that split being artificial, but nevertheless, that's the way things are. I would like to think that some of what we do, particularly what we do to support caregivers, but also the deprescribing and med optimization, would be equally applicable.
If I can just interrupt here, we have an attendee who's raised their hand. Lenise, if you'd like to unmute and ask your question, I've given you permission.
I'm sorry, I must have raised my hand by mistake. I apologize. I asked my question in the question and answer. Sorry.
No worries.
Okay, and then finally from David Carr, I notice when I attend in co-clinic for the IM residents, it's not uncommon to see patients on 2 different classes of antidepressants. Are there any situations where you might consider this, commonly with an SSRI in the morning and mirtazapine at night? There is now some emerging evidence that people who do not respond to one medication alone can get benefits from augmentation, which would be usually adding a second antidepressant from a different class. In other words, you wouldn't augment an SSRI like escitalopram with another SSRI like sertraline, but you may well augment it by adding mirtazapine, which has different mechanisms, or aripiprazole or bupropion, which are from a different class. I say all this while freely acknowledging we still don't actually know how antidepressants work. So when we say they're in different classes, it's not at the same level of knowledge of, say, when you're treating cardiac patients with medications, multiple medications of different classes, where you actually know what those medications are doing mechanistically. But there is some evidence that's growing that when you add a second medication of a different class to someone who's inadequately responding, that you can get maybe a third or more of those individuals into remission from depression. I don't know if that's what's going on in the scenario you're describing. I wonder if they're using mirtazapine just as a sleeping pill in that case. But at least there's some science behind it.
Terrific. So Eric and Katie, it looks like you've dealt with the questions in Q&A. I had one more question, and then we'll have to stop and put up a QR code for people to get their continuing ed. You talked about the importance of changing minds about medicines, patients' minds about, and you gave examples of pointing out the risk of the medicine. So is that, what else are your strategies for changing people's minds about medicine? And don't they also have the complication of somebody else prescribed it, right? So this is not changing their mind. Don't they you have to change other prescribing physicians' minds as well?
Yes, you do. And so we created for the Center for Perioperative Mental Health a detailed step-by-step deprescription, or what we call medication optimization intervention strategy that includes that, Nancy. As far as changing minds, I think making it really relevant to what's important to the patient is the most important thing. You know, you told me, Mrs. Smith, that such and such is really important to you. Therefore, reducing this medication is going to help you with that. And you know, in my experience, that's effective the majority of the time, even with benzodiazepines.
But what if they have been prescribed that by another MD?
Then we contact that MD and get their buy-in as well.
Okay, so you keep that responsibility and don't say to a patient, you better talk to your other doc about that.
Correct. I think that's a recipe for inertia in that case. And I think it's widely understood in, you know, our healthcare system, if you can call it that, that one problem, especially in the perioperative setting, but true for geriatrics in general, is that patients, as they go through different aspects of the system, will pick up a medicine from this person or from that person. They'll pick up a medication on the inpatient side, and for example, and then subsequent doctors are extremely reluctant to to stop or deprescribe a medication that someone else prescribed. And I think we need to divest ourselves of that thinking.
Thank you.